Thank you for inviting me, and today I'm going to discuss endocrinopathies in PMM2 and the different endocrine systems that are affected. As glucoproteins are involved in virtually all endocrine axes, abnormal end glycosylation can affect the stability, binding affinity, and linkage specificity of hormones, hormone-binding proteins, and hormone receptors, and downstream intracellular signal transactions. Thus, abnormal end glycosylation puts PMM2-CDG patients at risk for impaired growth, adrenal, gonadal, and bone health. I have some good news. Our disease-specific growth charts to capture characteristic growth patterns in children with PMM2-CDG was just accepted for publication in Molecular Genetics and Metabolism, and it's available online and then linked on the slide. I would like to point out that the creation of the charts was a true team effort. The project was funded by CDG Cares, data provided by Frontier in Congenital Disorders of Glycosylation Consortium, CDG Care, with the help of many families who inputted anthropomorphic measurements, height, weight, and also by glycomine corporations who provide us some of the data. And since the article is available online, I will keep the discussion on this brief. Growth in children with PMM2-CDG is compromised. The leading causes of growth failure are a combination of poor nutritional status, impairment of growth hormone, insulin-like growth factor 1 cascade, which can be caused by impairing glycosylation of the precursor peptides of IGF-1 and IGF-1 receptors, impaired glycosylation of the IGF-1 binding proteins 3 and the acid labile subunit, and the liver disease can affect also production of IGF-1, IGBP3, and the acid labile subunit profile. And on top of that, associated gonadal failure and lack of pubertal growth spurt. Now, why create the PMM2-CDG specific growth charts? They're helpful for understanding the growth pattern and pathogenesis of disease, and also they're useful for evaluating the effectiveness of new treatments in clinical trials. The data that was collected for the creation of the charts, it was de-identified growth data from children and young adults from 15 countries, 156 individuals with PMM2-CDG, 48% of whom were females, and the PMM2-CDG length height for 8 charts was based on 1,457 visits, and the data was available from ages 0 to 20 years, while the weight for age curves were based on 1,614 data points. Now, these two figures show the PMM2-CDG charts overlaid on the CDC height charts. On the left, the blue lines represent the median height for age of boys with PMM2-CDG, and also on the right, the pink lines represent the girls with PMM2-CDG overlaid on the CDC growth charts. And you can see that both the boys and girls with PMM2-CDG have different growth patterns when they're compared to the CDC reference data, and also that ultimately the final height is significantly impaired. When looking at the median weight for age for children with PMM2, you can see again that the blue line represents the boys with PMM2, and the pink lines, the girls with PMM2. And again, the weight for age percentiles for PMM2-CDG children are decreased compared to the weight for age for the CDC reference population. Now, Dr. Yao from Emory University create also a CDG growth calculator version, and included on the slide is the link. And this is the web page where, with the fields on the left to enter the data points. And the data that you need to enter include date of birth, date of clinic visit, sex, height, and weight. And here is, for example, the height for age, weight for age, and BMI growth chart for a female with PMM2 that's plotted on the PMM2 CDG specific growth charts. Now, moving on to the adrenals. Adrenal cortisol secretion is regulated by the hypothalamic pituitary adrenal axis. Corticotropin-releasing hormone from the hypothalamus stimulates ACTH production by the pituitary, which in turn stimulates adrenals to produce cortisol. Now, low cortisol, there is always a feedback between cortisol and ACTH, so low cortisol levels would lead to high ACTH production, and vice versa. High cortisol production would lead to high ACTH levels. So this is how our body is able to maintain cortisol levels in our body always steady. Now, in primary adrenal insufficiency, where the adrenals cannot make enough cortisol, the very low cortisol levels lead to very high ACTH levels. And in secondary adrenal insufficiency, there is decreased ACTH production by the pituitary, which leads to decreased stimulation of the adrenals, and again, low cortisol production. Adrenal insufficiency often presents with no specific insidious symptoms that can include low blood sugar, failure to thrive, reduced appetite, increased skin pigmentation, especially in the creases, and salt wasting in primary adrenal insufficiency. Other symptoms also can include low blood pressure, abdominal pain, and adrenal crisis. So our study was the first to indicate that adrenal insufficiency may be part of the PMM2-CDG phenotype, and maybe therefore can be underestimated. So we use simultaneously collected baseline cortisol and ACTH levels as part of a clinical care in a sub-cohort of CDG patients enrolled in the glaucomine natural history study protocol. And the results of the study showed that in a cohort of 43 patients, 25% had low cortisol levels with normal to low ACTH, and 5% had confirmed central adrenal insufficiency following ACTH stimulation test. Now, abnormal glycosylation, the mechanisms of adrenal insufficiency can be due either to abnormal glycosylation of the corticotropin-releasing hormone receptor, which could impair the binding of the corticotropin-releasing hormone and then the signal transaction to the receptor, preventing ACTH release and decreased cortisol production. Also, there can be abnormal N-glycosylation of the prohormone convertase enzyme in the pituitary, which can lead to decreased ACTH and cortisol production. Abnormal N-glycosylation of the ACTH receptor in the adrenal gland could lead to decreased stimulation of the adrenals and decreased cortisol production. And abnormal N-glycosylation of the cortisol-binding globulin could decrease cortisol's half-life and decrease the biological effect of cortisol. Early recognition of adrenal insufficiency and initiation of glucocorticoid replacement therapy as stress dosing could be life-saving. Annual surveillance is recommended with an 8 a.m. morning cortisol and ACTH levels. And if abnormal, for example, low cortisol a low ACTH hormone levels indicate central adrenal insufficiency, and low cortisol and high ACTH levels indicated primary adrenal insufficiency. A low-dose ACTH stimulation test should follow to evaluate the hypothalamic-pituitary adrenal axis for adrenal insufficiency. Now, let's move to the hypothalamic-pituitary ovarian axis. Hypothalamic-pituitary ovarian axis, typically during the first 6 months of age, when mini-puberty occurs, and during puberty onset, around 8 years in females, the hypothalamic-pituitary ovarian axis is activated by an increase of the GnRH pulses from the hypothalamus that stimulates the secretion of LH and FSH from the pituitary. Now, LH and FSH stimulate the ovaries to produce estrogen, which then estrogen production leads to puberty onset, breast development, and through a complex interaction between positive and negative feedbacks to measure periods. Now, LH and FSH also regulate egg maturation. Other hormones that are markers of egg maturation and reserve are adrenal hormone and beta inhibin. After the mini-puberty and until puberty onset, all pituitary hormones are low because the hypothalamic-pituitary ovarian axis is not active. And that's a period that you cannot really diagnose whether your hypothalamic-pituitary ovarian axis is impaired. Now, primary ovarian failure is a hallmark feature in PMM2-CDG female patients. Most females will exhibit elevated FSH and LH, low serum estradiol, low adrenal hormone, and low beta inhibin. Pubertal development is typically delayed, incomplete, or entirely absent. And females can present with primary amenorrhea and lack of breast development. And some females with normal puberty and premature ovarian failure have been reported. What is the mechanism of ovarian failure? Again, a lot of hormones and receptors that they're involved in the regulation of the hypothalamic-pituitary ovarian axis are involved. Abnormal glycosylation, for example, or FSH, and its receptor, plays a central role in the pathogenesis of the hypothalamic-pituitary ovarian axis. FSH modulates estradiol secretion, follicular growth, and andral formation. FSH receptor itself contains multiple end-linked glycosylation sites that contribute to proper protein folding, stability, and translocation to the plasma membrane. Both LH and its receptor, LH receptor, are glycoproteins. While abnormal glycosylation does not appear to affect LH bioactivity and bioavailability, it may impair LH receptor maturation and reduce its surface expression. Now, gonadotropin-releasing hormone stimulates gonadotropin release via its glycosylated receptor. Abnormal glycosylation may reduce GnRH receptor membrane expression. However, its clinical relevance appears limited, as most female patients have elevated gonadotropin levels. That means they don't have the ovarian failure does not start in the pituitary or the hypothalamus. Now, monitoring of puberty in females. Around age 8 years, pubertal development should be monitored by TANA staging of puberty at each visit. On the right, it shows the different stages of puberty. And monitoring lab measurements of estradiol, FSH, LH, adrenal hormone, and beta inhibin should be performed at each clinic visit. although mini-puberty has not been described in PMM2-CDG, assessing the same hormones during the 6 months of mini-puberty may help identify patients at high risk of developing ovarian failure. Now, this linear growth trajectory suggests that while PMM2-CDG females have a mute pubertal spurt, they experience a slow, gradual, and prolonged growth under the influence of estrogen produced by the adrenals and the low or absent estrogen produced from the ovaries. As a result of the low estrogen, the growth plates remain open and lead to a longer growing period later into the teenage years. Initiation of estrogen around 12 years of age will boost growth hormone secretion, pubertal growth spurt, and increase bone mass accrual. Increased bone accrual during puberty will decrease the risk of early development of osteopenia and osteoporosis in young adults. However, right now, there are no standard agreed-upon practices for hormonal replacement. This is due to a combination of lack of research on the subject and concerns about coagulation. But typically, females with ovarian failure can be treated with low-dose estrogen therapy, puberty induction around 12 years of age, start with 1/4 of a patch, and gradually increasing the dose of estrogen during the first 2-3 years. Micronized progesterone should be added after 2 years or earlier if bleeding occurs, and transdermal administration is recommended as oral estrogen replacement has been linked to thrombosis, and CDG patients often exhibit Congenital. Now, I usually recommend before I start estrogen replacement therapy, I always recommend that my patients see a hematology specialist just to make sure that their coagulations profile are okay, and then have annual visits to follow the patients with me. And in selected cases, prophylactic anticoagulation should also be considered. Now I will talk about the hypothalamic pituitary testicular axis. Normally during the first 6 months of age when mini-puberty occurs and during pubertal onset, around an average of 10 to 12 years for boys, the hypothalamic pituitary testicular axis is activated, similarly by an increase of the GnRH pulses from the hypothalamus that stimulates the secretion of LH and FSH from the pituitary. LH and FSH then stimulate the testes to produce testosterone, which leads to puberty onset by enlargement of the testes, sexual development, and spermatogenesis. Beta inhibin increases during puberty, and it's a marker of spermatogenesis. Like in females, after the mini-puberty and until puberty onset, all pituitary hormones are low because the hypothalamic pituitary testicular axis is not active. Antimullerian hormone peaks during the mini-puberty, remains high during the childhood, and then falls to the 3 to 4% of the childhood levels during puberty. High antimullerian hormone levels during puberty suggest decreased testosterone secretion. Like in females, the effect of hypoglycosylation primarily involves the FSH receptor cascade, and in males, FSH promotes spermatogenesis and testicular growth. Impaired FSH receptor function will lead to reduced testicular volume. Spermatogenesis has not been studied in PMM2-CDG males, and impaired spermatogenesis is a known feature in patients with FSH receptor mutations, suggesting that a similar dysfunction could be present in PMM2-CDG males. There is, as I said, very limited information on testicular function in males. Around 8 to 10 to 12 years, pubertal development should be monitored by Tanner staging of puberty at each visit, and measurements of testosterone, FSH, LH, adrenal hormone, and beta inhibin. And again, like in females, although mini-puberty has not been described in PMM2-CDG males, assessing the same hormones may help identify patients at high risk of developing testicular failure and help us understand the progression of, of the testicular, of the hypothalamic pituitary testicular axis. Now, boys with PMM2-CDG have, like the girls, they have a muted pubertal growth spurt compared to boys in the normative CDC reference charts, but their PMM2-CDG growth curves continue to gradual rise through the teen years, similar to girls with PMM2-CDG. The linear growth patterns in PMM2-CDG boys were surprising, as a couple of studies have reported normal puberty onset and progression in males with CDG. However, the reports are based on single testosterone measurements in a very small number of males affected with PMM2-CDG, and longitudinal evaluation of testicular function and testicular production throughout puberty and adulthood is lacking. So the growth patterns of boys suggest that there may be a gradual decrease in testosterone production during puberty, leading to a decreased pubertal growth spurt. Therapy for PMM2-CDG males with testicular failure can include low-dose testosterone therapy for puberty induction around 12 to 14 years of age, starting with 50 to 75 milligrams intramuscularly once a month, and gradually increasing the dose of testosterone during the first 2-3 years to full replacement, which could be 100 milligrams sub-Q every 7 days, testosterone gel or patches daily. And again, in selected cases, prophylactic anticoagulation should also be considered. Now, CDG Care is conducted a brief research study to better understand clinical practice patterns across the world as they relate to individuals with congenital disorders of glycosylation experiencing stroke-like episodes, arterial strokes, and or venous thromboembolism. And these episodes can occur at any stage, but the addition of hormone replacement therapy, particularly estrogen, theoretically increase this risk, similar to a hormonal replacement in other contexts. Due to the rarity of CDG, there are no standard guidelines for this management, and there are few publications to provide evidence for practice. Therefore, we are going to survey CDG providers in an attempt to gather real-world data about current practice patterns along with patients, and with the hope that this in turn lead to a consensus-based guidelines and more rigorous studies into this aspect of CDG care. Now, patients with CDG are also at increased risk for osteopenia, osteoporosis, and fracture, as many of these processes are required for bone formation, bone remodeling, and bone integrity, and can be negatively affected by impaired glycosylation. Now, the mechanism of bone disease in CDG are multifactorial. Abnormal growth axis function, impaired gonadal sex steroid production, suboptimal nutrition, immobility. All of this can affect negatively the bone health of CDG patients. And abnormal end glycosylation of collagen or anchoring of bone matrix glycoproteins such as rancol and its receptor, osteoprotegerine, I hope I pronounced it correctly, sclerostatin, bone alkaline phosphatase, and osteocalcin. They can all impair bone turnover and bone health. Now, Hypophosphatemia-like clinical picture can be seen in patients with CPI-CDG and PMM2-CDG. What is hypophosphatemia? Hypophosphatemia is characterized by a genetic defect in the alkaline phosphatase gene, leading to low alkaline phosphatase activity, elevated vitamin B6, and sometimes, not always, increased urinary phosphoethanolamine. Now, what happens in CPI-CDG disorders? In these disorders, they can present with hypophosphatemia-like picture because of inadequate anchoring of alkaline phosphatase on osteoblasts. That could lead to decreased bone formation and bone mineral density despite elevated circulated alkaline phosphatase levels. Similarly, abnormal N-glycosylation of PMM2-CDG can lead to hypophosphatemia-like picture. Treatment with alkaline phosphatase enzyme replacement therapy can help decreasing the osteopenia and the risk of fractures in these patients. And it's important to know if your child has a hypophosphatemia-like picture, because in these circumstances, therapy with bisphosphonates is contraindicated. Now, recently we had a report, an abstract on bone health and risk of skeletal fractures in congenital disorders of glycosylation, and it was an analysis from the Frontiers in Congenital Disorders of Glycosylation Consortium cohort. And currently we are working on a manuscript, and we are going just to present the very, very preliminary results. So here are the data analysis. You can see the fracture-free survival by the different colors, indicate the different types of CDGs. And our data analysis showed that by 5 years, the cumulative fracture percentage was 5, by 10 years, 14.2, and by 15 years, 26.5. And of those who experienced fractures, the median age of fracture was 9 years, with 60% by age 10 and 85% by age 15. Now, we are still working to get comparative general pediatric data to compare our incidents and our findings in the CDG patients. And also, the data is incomplete and underestimated because the majority of our subjects are still in childhood at assessment, so a lot of data censoring has occurred. And what we found is we found that a logistic regression so that the outcome when we correlate between CDG groups and fracture occurrence, there was no significant difference in fracture odds between the different CDG groups. And the only significant predictor was vitamin D supplementation, which was associated with an increased odds of fracture. And this may be reverse causation, as patients with fracture or those identified at high risk are more likely to be on vitamin D supplementation. And I think that's it, and I'm on time. Thank you.